Hey, good morning. Thank you for joining the What's New with COVID-19 webinar panel series hosted by the UAB School of Medicine. My name is Mary Ashley, and I'll be moderating today's session. First, I want to introduce our experts, Dr. Mike Sag and Dr. Paul Gepfert, who are both professors in the Division of Infectious Diseases here at UAB. Dr. Sag and Gepfert are going to give an overview today of COVID-19 news, such as current hospitalizations and vaccinations in the state of Alabama. They'll also say a few words on how to talk about COVID-19 with vaccine hesitant patients. So I think we'll go ahead and dive in since it's 6:30 on the dot. Dr. Sag, let's begin with you. Can you tell us just a little bit about the current state of COVID-19 in Alabama and in our hospitals?
Sure, it's unfortunately a wildfire right now, and the spark was July 4th, with Delta entering, people behaving as if the epidemic was over. I think that's understandable on one hand because our June numbers look so good, but this really kind of took advantage of the percentage of people who are unvaccinated, which at that time was about 64% of our population who was eligible were not vaccinated. And now it's just exploding. It's everything that we said back at the beginning, that Delta is a very contagious virus. It's different on many levels. The first thing is that it's somewhere between 2 to 5 times more infectious than the original virus, more infectious even than Alpha, the British virus we'd had. And it also is different in that it infects young people and makes them sick. And we didn't see as much of that before. So the classic person being admitted to the hospital right now are people who are under the age of 50 who are unvaccinated. And it's also affecting children, which we didn't see as much before with COVID pneumonia. So it's a different animal. Our hospital numbers are surging. I don't have recent ones from the weekend, but last week we were well over 110 patients in the hospital. That's different than, say, we were in June, where we might have had 3 or 4.
Thank you, Dr. Sag. That is definitely scary. Dr. Gepfert, can you tell us a little bit about the current state of vaccinations in Alabama?
Sure. So as you know, vaccines are approved for individuals 12 years of age and older in Alabama and across the country. And there's 3 vaccines available to us. The one that's available for all those age groups is the Pfizer vaccine. And Alabamians, we unfortunately are dead last or close to last in vaccine uptake. So we were vaccinating, our peak vaccination was around March, April. We were vaccinating around 45,000 a day. That's how we maxed out at that. But then more recently, we were down to about 5,000 a day vaccine doses. And then there was a slight uptick. There has been a slight uptick recently. I think people started worrying about, I'm just guessing, they started worrying about the uptick in number of cases, especially among young individuals, as Dr. Sag was mentioning. But we're still only 40% of our population has received at least 1 dose. And we know now with the Delta variant that 1 dose is just not sufficient. You need 2 doses to really provide protection. And that is only about 33% of the population.
So would you mind both saying a few words about what providers can say to patients who are vaccine hesitant? So if you have a patient come in who is just scared of the vaccine or for any other reason doesn't want to get it, if you would both just say a few words on what doctors can say to their patients.
Well, I'll start. First is to explore the reasons and not sort of jump in necessarily with a long lecture, but try to understand what they're thinking, where they are. Sometimes they have misinformation. Sometimes they're just hesitant, want reassurance that the vaccine is safe. So I'd start with almost more of a Socratic method in a compassionate way, saying, you know, this Delta variant is here. It's running through the country. It's running through our state and our community. I notice that you're not vaccinated. Can you help me understand what your thoughts are about it? And then stop and let them talk. And more times than not, they are open to ideas. Like, for example, they might say, I've heard that it affects my fertility. I heard that they aren't safe, that they're experimental, that this is something that the government is imposing on us, that type of thing, and just patiently walk through them. You answer one or two, maybe three questions, and in my experience, 80% of the time, they'll go out and get a vaccine very soon after, at least to say that they will. So I think that's the approach. There's about 20% of people who are unvaccinated right now, it's a guess, who just say no way, no how, and there's not much you can do there.
Yeah, I mean, I completely agree with what Dr. Sag said. You have to meet the patient where they are. And there's a variety of reasons, as Dr. Sag mentioned, as to why people are vaccine hesitant. One thing I don't think he mentioned is that there are still individuals in this state who don't have the financial means, and I know the vaccine is free. However, just getting to the doctor's appointment and finding time to get off work to do it, or to get out of childcare to do it. I mean, there's a variety of reasons. And actually there was a study that was done recently that showed that in fact may be the number one reason, relatively speaking to other states, why Alabamians are having a difficult time getting vaccinated. So that's something that could be helped out. There could be some of these physician offices that could help with that, to be able to do that. And then there's vaccine skeptics, as Dr. Sag was saying, and then there's people who've had, so vaccine skeptics, people who think that vaccines are never going to work no matter what vaccine, and that's a very difficult group of individuals to sort of sway over. And then finally, there are people who have just had misinformation, and I think they require somebody whom they trust, and it's not going to be me talking to the masses. It's going to be a physician who's taken care of them for a long time, to be able to lead them through this whole process.
One bit of data that I think works really well is, these are facts, but among the 18,000 people who died in the month of May, 17,850 of those deaths were among unvaccinated people. It's over 99%. And the same thing was true among the 10,000 deaths in June. We're waiting on the July numbers, but you can just look at the hospital and show that well over 90% of the people who are in the hospitals, who are in the ICUs, are people who are not vaccinated. So I think that goes to the efficacy. As far as safety, I think the evidence is pretty robust now that this vaccine is no different than any other vaccine that we get in terms of safety. There are rare side effects for sure, but that's true with every vaccine that we use.
Yeah, one thing that I would just like to mention about safety, not only, I think there's a lot of things that have been thrown around as to why people aren't trustful. One is it was made so quickly, but it was done quickly because we had a huge amount of government support with the prior administration, dumping a lot of money into it. And then Pfizer, which is the main company, had it's one of the biggest pharmaceutical companies, and they put in an enormous amount of money into it as well. And then you had volunteers left and right. It was very easy to enroll into the study. And then we had technology that we knew about, and technology that helped us before this started because of SARS-1. We figured out a lot of things there. And then we got somewhat lucky on a couple levels. One is that the RNA technology just came on the scene, and it's very easy to rapidly make a vaccine with this type of technology. And then finally, for whatever reason, vaccines seem to work pretty well against this virus. And I think it's because if you can tweak the immune system just right, to be able to recognize it more quickly, that patients will do better with this. And then finally, and unfortunately, the number of cases has continued, and it continued very huge numbers during the time we were testing these vaccines. And because of that, we were able to come up with an answer quickly that these vaccines worked. And then now that they're approved, I think it's interesting. They're not FDA approved yet, but that should come shortly. And they have a huge amount of safety information, much more than they would with prior vaccines, because now the emergency use authorization has allowed this vaccine to be given to millions upon millions of people. So we have an enormous amount of safety information. And like Dr. Sag said, they're not without their risks, but the risks are exceedingly small.
Thank you, Dr. Gupfert and Dr. Sag. That's very informative for everyone listening today. And I think now might be a great time to transition over to our Q&A portion. Anyone listening is welcome to drop their questions in the Q&A feature for Dr. Sag and Dr. Gupfert. We'll actually get started with 2 questions that we received prior to today's session via email. So one question from a provider says, my patients are saying, what is the point of getting vaccinated with the breakthrough cases we're seeing from the Delta variant? And that question's directed at either one of you, whoever would like.
So I'm happy to start with that. So from a personal reason, it's very important because the vaccines by any standard are 90+% effective against severe disease, even with the Delta variant. And this has been shown by multiple studies. So the second issue has to do with not, if you're interested in preventing infection, and it works on that level too. Now, we're still learning about this. There was a paper that was just published in the New England Journal from the British group with the Delta variant in the United Kingdom. And it showed that the Pfizer vaccine after 2 doses was 88% effective against symptomatic COVID infection. Now, the Israeli group has actually had not as great data, and it's still not clear why their data, it's not as effective, but it's still 40 to 50% effective against prevention of symptomatic COVID. And then it's 90+% effective against severe COVID, even in that setting. So for you yourself, it's extremely important to get this. Now, I'll say one other thing. We're just now starting to learn whether this is what happens to somebody who's infected with the Delta variant and they're vaccinated compared to somebody who's unvaccinated in terms of shedding a virus. And it turns out that when they're first infected, they both seem to shed the same amount of virus. However, within 4 days, the people who've been vaccinated, they start decreasing the amount of viral shedding precipitously. And I suspect that they're not very infectious after that, whereas people who haven't been vaccinated continue to be infectious. So from that perspective, I think it's very helpful as well.
And I think that tells us a lot about the pathogenesis of this infection, that it seems that the more prolonged viremic phase leads to worse outcomes. And so that's another way to think about what Dr. Gephardt just said. The other thing to keep in mind, I think it's worth pointing out, is that we do have treatments early on as antivirals, and that is the monoclonal antibody. And if people can get that in the first 2 to 4 days after initial infection or initial onset of symptoms, you can really almost abort the severity that would ordinarily follow, especially in an unvaccinated person. So it's basically passive immunity of sorts. You give an antibody that's very specific for this virus, and it sort of binds to it, takes it out, reduces both the severity of illness and the duration of illness. So I think that's somewhere we're hearing hints here that the pathogenesis is driven by prolonged viral replication. Drugs like remdesivir work, but they're given really late when somebody gets admitted to the hospital. We'd love to give that early, but it's 5 days of infusion. That's hard to, it's unwieldy to do as an outpatient. So new drugs are being developed that are oral, think like Tamiflu, that can be given that way, but they're not ready for prime time. So until that comes along, monoclonal antibody is the best way forward. 20-minute infusion, 1 hour observation. Most hospitals have this in the local area.
Thank you, Dr. Sag, Dr. Gupfert. We do have 2 questions in our Q&A, so I'll go ahead and get started with those. The first one is, when do you expect COVID vaccines to receive emergency use authorization for children under 12?
So they're working on that now, but the latest I've heard is around September. Hopefully by next month, we will have that. At least the application will be put in place. And obviously, we would like that to happen very quickly. I don't know if Dr. Sag has more information.
No, that's exactly what I've heard as well.
Okay, great. The next question is, for those who received Pfizer in December, January, are protected against serious illness 8 months out? And how long does immunity last from both shots of Pfizer?
So this is a difficult question. I will say that at 8 months out, the vaccines still look very good in terms of even neutralizing antibody responses. Beyond that, I think they're starting to decline, especially the mRNA vaccines. However, in terms of prevention against serious illness, they still seem to be long lasting. And that may be because serious illness is a combination of antibodies, both neutralizing and binding, which last longer, the latter, binding antibodies, as well as T cell responses. And so in terms of prevention of serious illness, I still think they're lasting a lot longer. I think the problem is that everyone's debating whether we need boosts or not, mainly because of this increase in infection in the Delta variant and vaccine breakthroughs. But they still look good from that perspective, serious illness.
And I'd add that right now, I think there's recommendations that are coming out saying that if the patient is immunocompromised, cancer chemotherapy, immune modulators for arthritis or inflammatory bowel disease, et cetera, transplant recipients, that they're recommending going ahead and giving a third shot now. Other folks, I think we should hold back for a couple of reasons. One, that the vaccine does appear to be working. And keep in mind that measuring antibody isn't the only thing. And we also expect antibody to wane anyway, because that's what our immune system does. That doesn't mean that the B cells aren't ready to respond upon exposure to the pathogen again. We don't have the B cells churning out antibody just forever for any disorder. And so the fact is the memory cells are there to respond fairly quickly if they get exposure. The other thing to keep in mind as we talk about measuring antibody is that patients will come in and ask for that. And I typically am not doing it because first off, the tests are highly variable and we don't know exactly what to do with the results, which is tough to say. Finally, new vaccines, and Paul, I'll kick this to you. I know that they're under development with different vector, if you will, not vector, but different formulations that have perhaps mRNA that's Delta oriented. Do you know what the status is of development of those vaccines that might be specific for Delta, different than the original vaccine that Pfizer and Moderna made?
Yeah, that's a good question. So when the first, the most vaccine resistant strain so far has been the Beta variant. Delta variant is about the same in terms of vaccine resistance. So the vaccines still work against it from a perspective of in the test tube. The problem is that Delta variant is so much more infectious than the Beta variant. And vaccine manufacturers have already produced the Beta variant, and I think they're working on the Delta variant now. I think what we need, this is kind of getting into the weeds of things. What we have to really have now is a correlative protection. And so then that way, when we go in and test a vaccine, we don't have to do an endpoint in terms of efficacy against prevention of infection anymore. We just need antibodies. And I think that's what they're doing with children. And I'm hoping that's what they'll be doing with a Delta variant. We do that with influenza vaccines, for instance. And so when we get that, I think it'll be much more rapid to be developed. I will caution, though, and say that it may be that even if you put the Delta variant vaccine in there as a vaccine, it may not work better than our current vaccines. And I think that's being looked at as well.
Thank you so much. We have another question that's come in the chat about drugs. So I'm going to do my best to say these two. The question is, with the availability of ECMO limited or non-existent across the entire Southeast, most hospitals have little to offer beyond dexamethasone and remdesivir. Do you have experience using the baricitinib and
Baricitinib?
Thank you. Tocilizumab?
Yeah, that's good enough.
Okay.
So maybe I'll start that we don't have a lot, but those things work pretty well. In particular, the dexamethasone. The thing to keep in mind is you conceptualize the pathogenesis is that the first phase and the first, say, 6 or 7 days after onset of symptoms is the viremic phase. And there's an innate immune response, mostly driven by interferon, followed by an adaptive immune response that can get out of control. In other words, the stand down orders that once the infection is brought under control, that tells the immune system just to chillax, if you will, is lost. And that seems to be part of the pathogenesis. So you end up with in some people, these cytokine storms that are raging out of control. And that's where the drugs like dexamethasone work extremely well, but also the IL-6 inhibitors that was just mentioned, tocilizumab and some others, will act by inhibiting the cytokine storm, but there's a narrow window where that drug particularly works right before someone, for example, gets transferred to the ICU. But the steroids are very helpful. Remdesivir, as I mentioned earlier, generally is given too late. The viremic phase is ending by the time that's given. The most important thing I think you can walk away from this webinar with is do not give, under any circumstance in an outpatient setting, steroids, systemic steroids in the first 6 or 7 days of illness. That will prolong the illness. It will increase the severity. We see some patients showing up at rapid test centers where it might be an urgent care center. The docs will just reach for the injectable steroid, give it to them like on day 2 as a diagnosis is made. And that really is a bad thing to do in terms of outcomes for patients. And it kind of inhibits that interferon response when it's really needed by the immune system to fight off the virus.
Yeah, I mean, I don't have much to add. Dr. Sag mentioned everything. And remember, he mentioned before that if you have a patient who's an outpatient, don't give them steroids, but if they have risk factors, give them monoclonal antibodies, because you can't wait until they get into the hospital. It's too late for that. Once they get in the hospital, as this physician was asking, you know, dexamethasone and steroids is a standard of care now. I'm sorry, dexamethasone and remdesivir is a standard of care. Baricitinib you can give to people who can't tolerate steroids. It works really well, and that study was done to compare, to show that it does work, but whether it works in addition to steroids, possibly, but I'm not sure that the jury is still out on that. And Toci is sort of the same situation.
The castlivimab is one of the 2 monoclonal antibodies that's in the Regeneron preparation. Take home point from this: the Regeneron preparation still works against the Delta variant. The Lilly preparation does not work. So we're not using that anymore. And none of the infusion centers are using that. So it's only Regeneron product for right now.
Thank you both. We have one more question. This may be a good question to end on and then get your final thoughts afterwards. But the question says, the CDC is stating that fully vaccinated individuals do not have to quarantine after COVID-19 exposure unless or until they have symptoms. With the breakthrough infections we are seeing and the transmissibility, even for the fully vaccinated, should we as doctors be more conservative and recommend quarantine to fully vaccinated individuals as well?
Well, I think that's really on the cutting edge. One thing you might do is if someone's had a meaningful exposure, and that's usually household contact, the Delta rips through households. It's really hard to have one person in the house who's infected and not have the others get infected. So one thing that could be done is hold the people who have been exposed at home and then test them on, say, day 4 or 5. And if they're negative, then I think if they're vaccinated, then they could go. People who are not vaccinated need to be held out. One thing that's raging in controversy right now in our community is masking of children going back to school. And this, I don't mean this to be political, although it's been made to be that way, but the bottom line is we're sending kids to school under the age of 12 who are not vaccinated. We're putting them in a room with 25 to 30 other kids. And it's likely with the amount of infection we have in our community that at least one of those children in the course of a week is going to come in with COVID. And once they do, those other children are going to have to be put into some degree of quarantine. So what kind of school year are we going to have if we don't minimize infections? So just from a practical standpoint, not only to protect the kids in the maximal way, but also to prevent a cascade effect of exploding cases within the classrooms, masking is, I think, imperative. And so if you're on a school board or if you're advising them, please encourage them to adopt that. Recently, a lot of the school systems, the larger ones, have moved in that direction. Good for them, but the rest need to follow suit, in my opinion.
Yeah, I would just add about the CDC recommendation. As Dr. Sag mentioned, this is sort of on the cutting edge, and their recommendation may change. I think there's a lot of factors that go into it, and it has to do with the expense and time and all that of doing this. But I do think that is a good approach, what Dr. Sag mentioned, in that this Delta variant seems to produce symptoms or cause infection much more quickly. And if by day 4 you have your PCR negative and asymptomatic, I think it's perfectly acceptable to go back to doing what you were doing. And then masking, obviously, you're preaching to the choir. I mean, it's just something that is known to be effective, and it's the only thing that we know to be effective to prevent transmission if in a population that can't get vaccinated. And you know, this is not going to be here forever, but we have the tools to be able to stop this, and we just need to implement them without getting political about it. I realize that it's inconvenient to wear masks. Interestingly enough, I bet most children I know that they are much less inconvenienced about wearing masks than adults are. So I think it's a great idea to be able to do that. And the plus will be that you will have less class interruptions, and you will be able to have in-person teaching, which I think everybody wants.
Thank you, Dr. Duckworth.